invited to this event as one member of the Swiss Academies of Sciences, and in my role as the president of the Swiss School of Public Health, because this may be one of the partners also in the mental health observatory. And I think it links well to what was discussed before. What is the role of academia and working in silos? I just spent one slide on explaining what that Swiss School of Public Health is, because it's a bit of a special case. It's an inter-university collaboration, as you see, of 12 universities. Public health is an enormous field. Very few institutions in the world have the critical mass to have a school of public health that really encompasses all the areas that you need, like Johns Hopkins and schools like that. And so we partnered. It's a community of will. Nobody forces us to do that, but we are convinced that it's a very good model to collaborate across universities. So we bring together more than 250 faculty from 12 universities, from 40 disciplines. You know, public health is not just about epidemiologists and medical doctors like me. It's about communication scientists, engineers, chemists, and they all come together as a faculty here and offer what we do not offer at each of the universities. So we have, you see here, we have 3 strategic pillars. One is teaching and training, which focuses on PhD education, where we really have a critical mass. So we have 400 plus PhD students enrolled in that particular area. Inter-university research, we heard about the silos and not being rewarded for interdisciplinary research. Maybe in the short term this is not true, but we embarked, for example, during the corona pandemic on a very large research program where we enrolled close to 1% of the entire Swiss population, which was not too bad, and it was academically hugely successful. But this was the common cause of supporting the pandemic management, was the main idea, and this is why all the disciplines contributed to that. And I think we have a similar case for the Ukraine now. And the third pillar is science to policy. So this is very important that we have a structured, formal relationship also with policymakers, for example, the Federal Office of Public Health, or also internationally. But let me now talk about the project in the Ukraine. And I'm not only me here from the project, but also Professor Victoria Yazenok. She is actually from Ukraine, from Sumy, which is close to the Russian border, close to Kharkiv, was very much affected and is still affected by the war. And she came to Switzerland and now works with me together at our institute and with the partners we have at Sumy State University. I think to understand the context, the context a bit better of the Ukraine, you need to understand that there is a series of developments and also trauma that happened over the last, let's say, 100 years. You see the Holodomor famine, so the death by hunger, which was really terrible in the 30s, World War II, the Chernobyl disaster, more recently, of course, the pandemic, and then, of course, the Russian invasion and the war that the country is experiencing now. So we also need to consider always against that background the issues we are looking at now. And the awareness for mental health was there before the war. So this was well recognized that there needs to be, on the public health, on the public mental health level, but also on the mental health care level, there needs to be development to strengthen the system. So this is just a quote from last year from First Lady Olena Zelenska, where she said mental health is one of the biggest global challenges. Absolutely true, we all agree, and of course, for the years and decades to come, it's a particular challenge for the Ukraine. And there has been some developments before the war, which is again strengthening public health, public mental health. There were some other initiatives to the far right, mental health for Ukraine. I will come back to that, which is has also started before actually the war, which is an initiative to modernize mental health care in the Ukraine, where we now contribute with our project also a bit to that. What the one missing piece is that there is little understanding how the population does at large. So there is no surveillance of mental health in place nor of important determinants for mental health. And this is where we went in, and very important to emphasize, we don't do that primarily as an academic exercise to publish, but really support the policymakers there, the decision makers, also the practice partners, with data that are really urgently needed in that area. And this is why we try to set this up, so a surveillance of public mental health. Try to be agile. As you will see, it's actually a cohort study. It's not a one snapshot study. It's a cohort study, so we are also flexible over time to pick up developments and embed new things into the study. And as you will see, briefly explain, we also do that at the same time in the canton of Zurich, which is quite representative for whole Switzerland, where we also will have participants from people from Ukraine who fled to Switzerland, who now live here, but also from the general population in Switzerland or in Zurich who are not affected by the war, kind of a control population. On the right side, I just love that pyramid, the health impact pyramid by Tom Frieden, former director of the CDC, which also emphasizes that we always think about healthcare when we think about the health system, but it's really the layers below, the socioeconomic factors, the ones we heard before, education, poverty, social networks, the environment we live with, built and natural environment, all these factors that really contribute together to health and also to mental health. And what we try to do, and I'm a strong advocate of that, I always try to think across this pyramid when we do studies, and not just as a single element of it, but we try to build in this thinking in our studies in general. So what we thought from the beginning is, we don't do this just as an academic exercise. We want to provide useful data for those who need the data. So we partnered with the Ukrainian authorities, with the Swiss Agency for Development and Cooperation, who has been doing work and supporting Ukraine for many, many years. So it has always been one of the strong partners of Ukraine, but also with the International Committee of Red Cross and our partners, again, that come into play, the Swiss School of Public Health. So we really tried to do something that takes multiple stakeholders, hopefully all relevant stakeholders on board, and plan this study together. So what we basically do is we have two parts, but that are connected, of course. So we do this population-based longitudinal surveillance of mental health. You see that we call them the MAP studies. So there is MAP-U, this takes place in Ukraine. There's MAP-Z that takes place in Zurich. We hope that there is going to be a MAP-C, C like children. It's very hard to do that from the beginning, study with children, but we do quite a lot of research with children and adolescents. So of course our hope is also to have at some point the population of children, adolescents included in that study. And on the right side, we try to support with research, again, these community mental health care services that are being built and developed and supported at the moment through this program, Mental Health for Ukraine. And we also look at one of these, we also already heard a digital tool to help people in that case living with depression, which is kind of a hybrid tool, which is a digital support tool, but always in connection with some healthcare provider. So some very briefly, some key features of the MAP studies. Again, yeah, it is ambitious, we agree, but we have a very strong partner with Sumy State University. They have a Center for Social Sciences. They are very used to do studies in the entire countries, in each oblast. That's how the administrative regions are called. They have colleagues, they have teams working there, so it wouldn't be possible just to naively think we can do a study from Switzerland. Absolutely possible. It's only possible because there are these strong partners in Ukraine. And you see, we try to get a random sample from people living in the different oblasts that you see here. So some are very close to the border, not directly in the conflict zone, because that's get completely out of control to do studies there. There are some in the middle and some that are a bit further away, although still some cities sometimes almost daily affected by the war and the bombings. And again, we have 4 age groups. We really try to look across the age spectrum of the adult population, And again, we have kind of two additional populations. One is study populations. One is those Ukrainians who had to flee to Switzerland, and the general population living in the canton of Zurich. And this setup really allows us to do also multiple comparisons, across time, but across many different groups of persons. We focus, at least in the first place, on the common conditions that we also think may be affected or are likely to be affected by the war: post-traumatic stress disorders, depression, anxiety, alcohol use disorder, and also bodily stress syndrome. Of course, we measure more. This is not a question, but this is the focus right away, because these are also the numbers, some prevalence numbers and burden of disease numbers that the Ukrainian authorities need at this point. I don't want to go into details, but of course we have to work with questionnaires, with the instruments that are well established, and we went through quite a process to select those, fully aware that this does not replace a structured clinical interview, but there is several measures we will take to make sure that we do not completely overestimate the prevalence of these conditions, which is the case often with these instruments that are tailored to be sensitive to pick up symptoms readily. But we have to work in these situations, of course, with instruments, because of the situation, because of the size of the project. Then the organization is, again, we work really very closely together with Sumi State University and our teams. So we do our respective studies, of course, in a very coordinated way. We have the data coordinating center for now in Switzerland. What we also plan now for 2 years. And then we will discuss whether it makes sense to hand this over also to Ukrainian authorities. Of course, the ideal world would be that this transitions to some long-term surveillance. But we will see how this develops. And again, we work very closely with the Mental Health for You project and the Swiss Agency for Development and Cooperation. And it's going to start very soon. So in a month from now, we aim to start with the enrollment. So almost everything is in place. We get the random samples very soon, so we're going to start very soon. What is also important, we do the assessments. Again, it's a cohort study, so people are enrolled and then followed over time. We send them questionnaires and the stuff every 3 months. It's a good retention measure. Sending it every year, 2 years, people forget and may not participate. So this is one thing, but we also try to get some of the dynamics over time. So we also did that during the pandemic. In the other studies, and it proved to be very useful also to pick up signals from more recent developments that will happen over the next years. The other project, again, linked project is, again, these mental health, community-based mental health care services that are being built up in the communities. So you may not know that, but a lot of the mental health care in the Ukraine is still happening in pretty closed institutions. Once you're in, it's not that easy, as I learned, to get out, and the care is not optimal. So what this initiative tries to do is to bring the services to the community embedded in the social environment people are in. So that's a goal. And what we will do, it's well embedded in the cities where they started doing that. And what we will do is we will do a so-called process evaluation. So we will look how these services are reach the people they are supposed to reach, how effective they are, how they're adopted, how they're implemented, how happy people are with these services. And what we try to give that back to those who run the services, those who oversee it, so to turn that hopefully in kind of a learning health system, so that they can learn as they go. The second is that we also go through a more complicated causal inference exercise, where we try to look at mental health outcomes in regions that are supported by these new community-based mental health care centers versus those who are not. And finally, we also want to look a bit more in this I Fight Depression tool, which is available in many languages in Europe, also in Ukrainian. It still needs to be a bit more developed for Ukraine, but we want to see how it's going to be picked up and how useful people perceive it to be. What we also want to do, so these are not real data, we just want to show you, we really want to bring the data back as soon as possible. This turned out to be super useful during the pandemic, so we don't wait with nice publications, which come years later. So we immediately publish the results online as soon as we think they are valid, of course, so that people can really look at the data and in a very dynamic way, and also look at regions they are particularly interested in. So we really tried to copy that from a large project we had during the Corona pandemic, because it turned out to be really useful. So finally, this is what we tried to do. We tried to bring together multiple stakeholders in this. Again, this is not a purely academic exercise at all, so we are very well connected by now, which has also been one of the challenges in the development, we have to admit. We are very well connected now to the authorities, both in the Ukraine, those in Switzerland, that's important. So I think we are well embedded in the whole system, and we hope to inform really decisions that need to be made about public mental health, about mental health care, and ultimately what we also try to serve, that's my personal opinion, how we should serve as scientists, the honest brokers. I don't know if you know that concept, but it's a concept where we really try to be available, try to understand the needs of the decision makers, and then propose to our best knowledge and compatible with the evidence advice on options that are around for dealing with these challenges. So this is how we see our role. We won't decide anything, but try to support those who need to make decisions. So yeah, that's it. Brief overview of the project. Happy to take any questions.
Thanks, Milo. That's a great overview. So can I suggest we maybe just have a couple of minutes just to get questions and answers around Milo's contribution, and then we might just finish up with some general reflections. So questions and comments around Milo? Yes.
Thank you so much. Great presentation. I'm really excited to hear about the map work. One of the things, I'm not sure if you're aware, we are also working with First Lady of Ukraine on the national mental health strategy, and as part of that we reference the MMAP, which is very close to your map, which is measuring the mental health of adolescents at the population level, which is a culturally adapted, clinically validated assessment tools that we are implementing globally. And the intention is to develop a global set of indicators on mental health, looking at child and adolescent prevalence from 10 to 19 years old. So it'd be wonderful to think through with you how we might link up and maybe even start with Ukraine. This is something that we haven't actually rolled out in Ukraine yet. More recently, we integrated the module on mental health from our MMAP into MIX, which is our flagship household survey that UNICEF implements globally. So we're just curious how we can connect the dots, because the data gap for children and adolescents is quite large.
Very good, very happy to talk about that. And I think one of the major decisions also for children and adolescents is always how to, it's very sensitive to enroll them in studies, and I think either you do it through the parents who may already be in a study, like population-based studies like we have. And another approach that in my view is very good is like the more school-based approach, where you have randomly selected schools from different regions, different backgrounds and so on, where you have the children and adolescents in their social context. So, but we can discuss it. I'm very happy to discuss it. Make sure we align the instruments so that we make our data comparable or work together.
It looks like we have the same people, because we have Welcome Trust and WHO as
Very good.
Connections probably are maybe not directly, but indirectly.
Yep, very good.
Okay, Ian.
Ask that further, Zainab, because obviously this is a situation, it's a very difficult situation, fluid situation. There's a range of different agencies and academic kind of groups. So you can comment a little bit more on how that might come together. I mean, in a lot of disasters and a lot of situations, you tend to have various sets of studies get set up.
Yeah, exactly.
Not necessarily well coordinated. They may run across the table. And these are terribly challenging times, obviously, for people in those communities. So Zainab may be able to comment on this as well about, there's the international agencies, as you just said, like UNICEF and WHO and UNESCO, and you'll have, Doctors Without Borders, you'll have academics, you'll have people who've got pre-established relationships like you do, in areas. Like, can you give us some sense about, how that can work best for people in the Ukraine? You've emphasised the other thing, I think, what's to be fed back, which is really important. But always does worry me the degree of lots of people with interest, but how does that coordinate? How does that really work with people who are
No,
living in this
it's a
situation?
very good question. I mean, what we learned through these contacts, also through the International Red Cross, they are really working on the acute response,
Right,
and
yeah.
really deal mostly with that. We do not address necessarily, of course, to some extent, we also address the acute situation,
Yes.
but we really have a longitudinal and more long-term outlook. And I think this is where the organizations come into play who are there, have been there for quite a while and still there. Like in this case, it was the Swiss Agency for Development and Cooperation that have established this long-term contact. So I think this was in our context the partners we needed to align with. But it took a while. It's not that easy. They also need to gain trust. There is a new player, blah blah blah. So I think that the great strength was that there is a great need for this type of population-based studies, which everybody acknowledged. The other thing was we had these very strong partners at Sumy State University who are all over Ukraine. Yeah. Without that, I think forget it. So, but I think these are some of the pieces, and we really don't focus on the acute, on the response that is now close also to the war zones or those who return and so on, which is again what the Red Cross is, for example, doing.
I think that point is really relevant to us because I think when it comes to emergency context, especially like complex emergencies, we would often not recommend doing prevalence studies anyway because we rely on estimates that really tell us what we need to know to develop and implement, emergency response services. So I think that captured. But I think what you're doing in terms of setting up the foundation in certain territories within Ukraine that you could roll out more broadly, hopefully once things kind of settle down. I think that is very smart. Yeah.
Can I make another comment, John?
Yeah.
In a lot of crisis work, as you said, and just as Anna was emphasising, there tends to be an emphasis on the acute crisis. Obviously, the situation in Ukraine is one of ongoing conflict, and the real sort of mental health burden in many of these situations is not the acute crisis or the acute situation where communities respond, but what really happens over time. Yeah. So the fact that you are doing the surveillance over time is so important. Yeah. But do you want to give us some insights into how you see that as panning out? Like how long is it going to go on for? Because really, I think what we tend to underestimate the longer term impact of many of these things and just focus on the crisis, and if it's seen to sort of settle down, then people retreat again and just say, well, there was and I think a misunderstanding about mental health and well-being, about crisis responses versus enduring and prolonged stressful situations, which tend to have much bigger impacts then on children and young people and on communities over the longer term.
Yeah, exactly. I mean, this is what we try to do, to capture it over the longer term. I mean, the challenge will be to retain, have people staying on the study. And there is, we have a lot of discussions. What is going to be the participation rate? How long are they going to stay? Some say it's still stigmatized quite a bit, mental health, and people are very cautious participating, making sure we are not coming from the enemy side. We also have to build trust towards participants and all of that. And some say, it's so relevant, it's obvious that many will participate, right? Some argue, others argue, oh no, people may be cautious. We really don't know yet. But we have quite an agile approach to the whole thing, so which hopefully helps.
Maybe just to say, I think for us long-term in terms of sustainability and looking at long-term issues, we are looking at school-based surveys that
very good.
Yep.
As well as household surveys that are rolled out nationally.
And I think it's great that you had the First Lady say it is really important. It goes back to the thing that Nouriel was saying earlier on. I think in crisis, and people go, oh, the immediate needs are something, they're the physical needs, or and to ignore a lot of these other factors about what might really need to be done continuously in terms of working with communities to understand the longer term impacts.
Now, we've got somebody at the back here who's not a panellist, and it'd be good to hear from them.
Hi. First of all, I think your work is remarkable. I mean, UNICEF has for years been doing, I think, the most important survey of mental health disorders in children in 70, 50, 60, 110 countries. And I'm from the Child Mind Institute, and we just started a global center for children's mental health funded by the Stavros Niarchos Foundation. And we realized that the way to do a survey is to partner with UNICEF. But what you're doing, I think, is quite unique because the crisis isn't over. Schools are still being bombed, parents are still being killed. So the information you're going to get for us is going to be one of not the results of a crisis, but the results, I think, of chronic crisis, which is very different. It reminds me of children who live in abusive homes where the sexual abuse and the physical abuse goes on for years. They look much more damaged than a kid who we take out of a home. So I compliment you. This is really a challenging and an extraordinary study. So I have a question. I have a comment from the last panel. Sure, it's okay. I'm Harold Koplowitz. I'm from the Child Mind Institute. I think the word demoralized doesn't get used enough. I think people use the word depression when they mean demoralization. Terrible things happen. We lose people we love. For a teenager, we don't make the football team. We fail a course. We feel demoralized. Antidepressants don't work. Cognitive behavioral therapy doesn't work. It is part of the human condition that when terrible things happen, we feel terrible. And I think we should use that word more because it's not a matter of well-being. It's a matter of dealing with hardship. The other piece that really struck me is that when you ask people with bipolar disorder, the Millikan study, they want a test. And I think psychiatry struggles in a way that no other field of medicine struggles because we don't have an objective test. And so that if you have bipolar disorder and it's a gene or it's a connectome in your brain, and you could say, yes, you have it. It might be mild, it might be moderate, it might be severe. It's no longer that spectrum. Do you mean? And you do need to take lithium, or you do need to go to sleep early. And if you stay up late, it's kind of like people who have seizures. If your sleep gets disturbed, you're more likely to put yourself at risk. And if there's a message, I think, at Davos, it really seems time, as far as I'm concerned, for a multi-billion-dollar fund to research psychiatry. Do you mean to help us find, answers to this crisis in a way that we haven't done? And I constantly use the example of a small hospital in the United States called St. Jude's, which is a tiny 78-bed hospital in Memphis, Tennessee, that this year raised $3.9 billion for 78 beds, and there are 15,000 kids in America who have cancer. And we lose more kids to suicide than we lose to cancer. And if there was ever a time, I think this is the tipping point right now, people are talking about climate change, they're talking about the mental health crisis. It's time for the masters of the universe who are here to say, we can do this. It's not impossible.
So can we ask Harold, are you influencing them? You're very good at this.
I'm definitely in for this, I have to tell you. And it's really interesting. You notice, you talk to people like Bridgespan, and they'll tell you that the big foundations aren't in yet. But billionaires are. The Bombers gave $350 million to Oregon. You see that the Schwabs are giving tens of millions of dollars. The Mackenzie Scott must have given a few $100 million to several different mental health organizations. If there was ever a time for us to lean in, I think it's right now because we've been left behind in many ways, and this is it's truly a global problem. Whether you're rich or poor, if you get real common treatable mental illness, you need effective treatment. Otherwise, your life gets destroyed.
Yep. I mean, I couldn't agree more. It's an area. I mean, it's a combination of. I don't want to hide that it's not easy to find funding. By the way, I mean we're very happy that the Swiss agency very likely supports that and others, but it's hard. And I feel there is a lack of sense of urgency.
Yes. And I think
both for mental health, but also for the situation in Ukraine, which for me is depressing to some extent. But it's really this sense of urgency. In Corona, I mean, we funded our studies relatively easily, and here it's really a challenge because people don't, and it's not our priority for funding and so on. That's not
as evidenced by our Congress, that retired already. But we just moved, the Child Mind Institute just moved to a new home with 82,000 square feet of space. We went from 29,000 visits to 61,000 visits. Our budget went from 40 million to 136 million during the COVID effect. But something just happened that made me think there's a change. So we're moving into the new space. If you ever go to a children's hospitals are filled with beautiful artwork. Artists donate, people donate their art. That never happened with mental illness, with child mental health disorders. For the first time, we have 10 world-renowned artists who are donating multi-million-dollar art to us. I mean, now we have another problem. We have to get insurance. But nevertheless, I think it's another sign that the timing might be right for us to stand up and start really as a group talking about this.
Very good.
Yes. Can we have the mic down here?
Thank you. Speaking for us, I must say, important people.
Hi, my name's Harry Mander. I'm from the Wellcome Trust. I'm not an expert in mental health. I'm actually sort of subbing in for somebody. But I would like to say that one of the challenges, one of the key areas, 3 of the key areas that Wellcome is focusing on over the next 10 years is mental health. And last year we spent 49 million, and last year was 112 million. The year before that was 40 million, and I think the focus is on mental health as one of our 3 core areas. So, and I know that we're working with you as well. So, just to say that philanthropists are engaged.
Absolutely, no, and we are aware of the calls there. Also, Botnar Foundation will open a big call this year, so we're also hopeful
obviously
that
more needs to be.
Yeah.
Sure.
Yeah.
That Wellcome thing is a major kind of initiative. It is interesting, though, the Harold sort of contrast, the sort of money, and we're very grateful for the money we've received. You know, the differences in zeros between a number of the things we're trying to do and what has happened, like childhood cancer being a classic, other areas. You know, there is still a long way to go, and I think Nouriel alluded to this before about people seeing it as an add-on thing. Michael Spence was saying like an unknowable kind of thing. There are other challenges that we face. It's great to have Wellcome taking that forward. I think the question is, how do we leverage that, you know, in other agencies? Yes, and I think as we were discussing with Cara earlier on, the global mental health funding kind of movement's trying to coordinate that. And I'm glad that Harold's here because we can pick up a point with Zainab. The child and youth area, though, within that remains seriously neglected. And there's partly a vicious cycle of lack of researchers, lack of people, lack of thinkers, like the child mind issue to drive that. The mental health, we've looked at this in our own country, the mental health research that goes on still largely goes on in adult populations with existing disorders with relatively small sets of areas. And so there's also, we've had a big emphasis in Australia on earlier intervention, on trying to promote prevention, earlier diagnostics of kids with a disability and other sets of areas. But really it has been really neglected. I think we had a forum yesterday where people were making the point, whenever anything happens, we had a WHO here earlier, people go, well, infection, and then cancer, because people care about that. And by the time you get down the list...
It's one of our least funded areas, I have to say.
The American Academy of Pediatrics came out last year and said that the most common illnesses of childhood and adolescence are no longer infectious disease, is mental health disorders. And we have a generation of pediatricians who never took a month of either development and behavioral pediatrics or child psychiatry. So if this is the moment where if this is 30 or 40% of what they're seeing, they need to be part of the Army. You know, we have to figure out how you fund training them or how do you change the reimbursement rates. But the Army is very small to fight this crisis.
So Shannon's got an issue.
I'm Shannon O'Keefe. I work for IFM Investors, and I was actually John's research assistant 30 years ago when we worked together. So I've had a lifelong interest in work, and one of the reasons why we came here to look at this and the real clear connection with mental health is it's actually workplaces that are reproducing mental health, but they're also impacted by mental health that is happening in other parts of the community, and they're so poorly prepared to deal with it. You know, from a risk perspective, so now I work at IFM Investors, we're the 6th largest infrastructure owner in the world, is we want to understand how our workplaces can be safe in the broader sense. But I think what I've been thinking about is what can we learn from the climate movement around these things? And it's when you got investors involved to really supercharge both the investment in the understanding, but also understanding the solutions, is we have a direct interest in this because mental health claims are increasing broadly. We know those claims are very complex. We know they're very expensive. And it's also harder to get people back to work like you might be able to with physical claims. So we're here because we want to be part of a multi-stakeholder solution. Someone asked about civil society. You know, we represent a big pool of capital. So, you know, I came here from Australia because I want to have that conversation with other people about what we can be doing from our perspective as significant owners of our workplaces to help understand but also provide real solutions that help workplaces not be, particularly given the mega trends that are happening, continue to exacerbate quite complex mental health situations.
Good. Thanks, Shannon. Well, that might be an appropriate note to finish on, unless there's been some real enduring participants here, and some of you haven't asked questions or made comments. If you'd like to make any observations before we close, I'm happy to make an open mic. But otherwise, feel free to join us. We're happy to move into informal discussion, and we're going to be hanging around the Hard Rock Cafe with some funding for drinks. So please, if you do have the time, hang around, and because it's the informal discussions where you can often probe in detail.
We just pick up Harold's point because just for us to be here is incredibly expensive, and it wouldn't, without the support of the BHP Foundation, we can imagine we wouldn't be able to do this. Obviously, Harold and others being here to try and influence big investors, big philanthropy, to have it continuously on the agenda. That's quite a struggle in our own area to get that far. Yeah. We have to work out how to do that.
And I think Shannon's part of it, because they made a contribution too. IFM investors.
Yes, and thank the other people who supported, including IFM investors and others, to continue so that our voices are not lost.
Yeah.
Thank you so much. Thank you everyone for
Thanks.
coming.